Hello, everyone. Welcome back to another episode of Forward Physio. I'm your host, Noah Mandel, and today I am joined by arguably one of the most special guests I could possibly have on the show, and that's because this guest is the first one that I ever had on Forward Physio. He's the one who kicked it all off, and that is Mr. Adam Meakins. Adam, thank you for joining me again.
Hi, Noah. Thanks for the invite back. Always a pleasure to speak to my favourite Canadian physiotherapist. Thanks for the invite, mate. Looking forward to the second time round.
Yeah,
Hopefully, as
me
I
too.
say, it was as good as the first one. We shall see.
Hopefully. I actually have a funny story about the first one. I was so nervous. It was my first ever podcast, and I didn't have a good setup or anything like that. And I wanted to put my camera up on a potted plant, and I knocked it over like 2 minutes before we actually began. So I basically did the whole podcast with my feet in soil.
There's some analogy about maintaining your groundedness or being grounded. I think there's somewhere with doing a podcast with your feet in soil.
Yeah, that's a good way to put it. Anyway, so Adam, I'm really excited to chat with you today. We added a sort of different structure for a podcast than we normally do. And we wanted to go through some case studies today. But before we do, my first question for you is, do you ever get scrutinized online?
Do I ever get scrutinized online?
Yeah.
Yeah, all the time, mate. Every day, every post I do gets scrutinized. It's part and parcel of being an outspoken critic. It means you are going to get scrutinized with what you do. You're going to have people criticizing you because you're criticizing them. So, yeah, absolutely.
Yeah. When I go through your comment section, a big criticism that I often see is that you just say what doesn't work and you don't do anything with patients and you don't actually help anyone. And that is a big reason why I wanted to do this podcast, how we're doing it today, because we're going to go through a few case studies and we're going to actually be able to understand how Adam Meakins works with patients.
Yeah, hopefully this is going to be, say, a little bit different from the usual podcasts and gives people who do like to throw those accusations at me something to think about and ruminate over, that perhaps, I'm not just somebody that just says nothing works, and I do actually help people when I see them, which I think I do.
Yeah. Let's just not go through the case study and then you say, I wouldn't really do anything for this person.
There's always something that can be done. And I think there's always some assistance, even in cases where everybody says, oh, there's nothing left to do here. I always say there's always something you can do. There's always something you can give somebody some hope or guidance or direction on. It may not be the most massive life-changing event or, massive effect, but there's always stuff you can do.
Right. Cool. So I think when most people think about you in terms of what you do, you teach a shoulder course all around the world. So we have a couple of shoulder case studies. We also have a low back one. There's a lot of myths around low back pain, which is why I think you post a lot about it. And
Yep.
I think that's also going to be one that people are interested in. So why don't we start with the low back one? And I'll actually be able to share my screen here so that anybody who's on Spotify or YouTube can just also look at this case study that we created. Adam, can you see it?
Yep, can see that.
Cool. So first case study here is our low back pain one. We have a 35-year-old male. He's had recurrent low back pain since his mid-20s, one episode of left-sided sciatica at age 26 that resolved over time, and no other significant medical history. He works a desk job, generally low levels of activity over the past several years, so he's decided to get in shape and start going to the gym. Now, about a month ago, he was deadlifting and he hurt his back, his low back, and he believes that this injury happened because of bad form. But as you speak to him, you sort of get the gist that he actually increased his load and his volume pretty quickly after this relative period of inactivity. So he stopped training immediately and has been resting ever since. The pain's improved since he first heard it about a month ago, but it's plateaued over the last 3 weeks. He has a low-grade constant ache across his low back with sharper pain when he's bending forward. No symptoms going down his leg, no numbness, no tingling. And when it comes to how he's moving, he's constantly bracing his core and maintaining a rigid upright posture throughout his daily tasks. This was advice that he was given by a previous physio, where he should brace his core and try not to lift with his back too much and squat down when he's picking things up. So he's been doing this before he got hurt and now after as well. His pain increases again as he's bending forward, when he's sitting with a slouched posture, and he found that walking actually helps him feel a little bit better. His goal is to just get back to the gym confidently. So, Adam, with someone like this, what is your thought on the movement patterns that this fellow has adopted over many years and before and after this injury?
Yeah, so this is a case that is really begging for, a sort of graded exposure type of approach to try and, combat some of the beliefs and expectations and sort of narratives that he's probably had for a long period of time, given by social media, friends and family, and also, of course, other healthcare professionals. His movement patterns and what he's doing it's not unusual. It's not weird. It is just not the most effective thing, I think, to be currently doing in his current situation. What we want to really try and get across to this guy after we've, fully assessed him and excluded all the potential specifics or serious issues, which it clearly looks like there isn't anything here based on his presentation and history, is start that sort of compassionate, careful, slow education, reassurance, building up resilience and robustness back into somebody who probably feels a bit worried, a little bit anxious, a little bit fearful based on his beliefs and expectations about what back pain is and what's going on.
Got it.
So with this guy, it is a very sort of careful and slow approach, which is often quite challenging and time consuming and demanding, I think, for us healthcare professionals, which I wonder why I think is probably why it's not done by many, because it isn't a quick approach. It isn't a simple approach, and it requires compassion, care, time, and a lot of confidence to do well. These are the types of patients where I feel therapists often rush in looking for the quick fixes, the immediate symptom modification and relief type of approaches. And there may be a role for that. I'm not going to completely exclude that as a potential thing we could try to do to give him some reassurance that his pain is modifiable and changeable. But again, I think that comes with this sort of graded exposure approach, doing some movement-based type tests to see if we can modify his pain, maybe violate some of his expectations that he anticipates something is going to hurt, and we actually show him that it doesn't. And I think a good place to start here is probably just with his sitting positions. So normally with these type of people, because they've been told to brace and maintain their upright posture to prevent, all the nasty things going on in their lower back, all the biomechanical juju and bad men that often get explained as happening, discs being jammed donuts and lumbar kyphosis being bad, and you've got to maintain the lordosis all the time. I think trying to re-educate him through experiential learning rather than just education, by showing him that he can adopt different sitting positions that will hopefully make him feel more relaxed and less painful, rather than probably this over-braced, over-corrected upright posture that he's likely to have, is a really good place to start. And also perhaps looking into trying to get him to relax his abdominals with some sort of breathing techniques to try and, again, just to hopefully prove to him that he can let this guarding go and it isn't going to cause him any pain. If anything, it might make him feel more relaxed and it could reduce his pain. And then if that does, and it starts to have this good result that we're hoping for, and he starts to feel a little bit more comfortable in a bit more of a slouched, sitting, relaxed posture, then we can start to experiment with a little bit of moving whilst he's in these sitting postures. And again, starting to lean forward and bend over whilst they're sitting down. Great way to gently encourage lumbar flexion. Again, without bracing, without trying to maintain lumbar neutral, pelvic neutral positions, is a great way for them to realize that their back is probably able to tolerate these things before we even take it up into a standing position, which is what I often get accused of. Everybody thinks I'm just going to ask somebody like this to go and do a 200 kilogram 1 rep max deadlift to violate their expectations. Now, I'm a movement, I'm a movement optimist, but I'm not a fucking idiot.
Yeah.
It's about graded exposure. That's where the word comes from. It's about finding something at an easy level that they can tolerate, and just showing them that their body is able to tolerate that and building from there.
Mm-hmm. I want to ask a little bit more about the graded exposure approach that you take with them. But before we do, you mentioned that the first step is excluding sort of these more nasty things that may be going on. And that's the point of this case study, is that there isn't those things going on in this instance. But just in case there are people with back pain listening to this podcast, or people that just aren't so familiar with these more serious things, can you just briefly discuss how to spot them so that people can understand when they can start to actually follow this graded exposure approach instead of looking for these more serious things?
Yeah, sure. So with a case like this, which is obviously got a clear mechanism of onset, so doing something and then either doing it or immediately afterwards, you had this really acute, severe episode of back pain, particularly with a lifting type of mechanism. The initial thought is going to be some, serious injury to a disc. That's probably our most likely serious thing to try and exclude. And one of the really rare but really serious complications that can happen with disc injuries is you can get a central herniation that causes central stenosis and causes what's called cauda equina syndrome. So cauda equina syndrome is very severe compromise to these lower nerve roots centrally, which then produces often bilateral symptoms. So it's bilateral leg pain, and it often radiates down below the knee as well. But it isn't just the pain, because severity of pain is a very poor indicator of severity of structural damage. So pain alone isn't really a red flag, because even minor innocuous back problems can have very severe debilitating pain.
Mm-hmm.
It is the other features around it that's causing us more concern. So the main one will be severe motor loss. So if somebody is feeling that their legs are buckling and collapsing underneath them as they're trying to take a few steps, so they've got this real severe weakness of both legs, normally the upper legs, so the quadriceps are feeling weak. And then they've also noticed that they've lost sensation in and around their sort of genital areas and down the inside of their thighs, which is often referred to as the saddle area. So imagine a horse saddle that you're sitting on. Anywhere that comes into contact with a horse saddle on your legs, if that doesn't feel normal, that again is also giving us an indication that these nerves have been quite severely affected. And then the other one that sometimes gives us the clues is bladder and bowel problems as well. So normally it's incontinence. So people find themselves accidentally leaking or feeling that they've defecated themselves and things like that without noticing. That again is quite an alarming concern. This is telling us again the motor function around these muscles that would normally control this has been affected severely. And these are the things that we want to get checked out sooner, because they often may need further invasive interventions to try and obviously reduce the damage to the nerves and hopefully improve the recovery. And it may not always be surgery. It can be surgery that's needed, but sometimes they might need quite high dosage of steroids to try and reduce the inflammation around the nerve as well. So they may have to, have some more medical assistance and interventions there.
Okay. So as you said, that's pretty rare. That doesn't happen very often.
No, we are talking probably less than a 1% incident with all sort of low back pain.
Right.
So, it isn't the most common one, but it does unfortunately cause sometimes long-term problems if it's not identified quick enough and it's not acted on soon enough, possibly.
Right.
Maybe.
Right. Okay. All right. So let's go back to that graded exposure approach. For someone who has been told by a previous healthcare professional that they shouldn't be bending over and that they should have a braced core and not lift with their back, and they do that for years, that becomes a pretty cemented belief in their mind. And I think a lot of clinicians struggle with the concept of trying to break someone out of that line of thinking. And as you said, the way to do it isn't to get them to lift 200 kilos in a deadlift right away. That's going to make it a lot worse. So how do you try to go about having these conversations with people that seem like they're a little bit more firm in their beliefs?
This is a great question, and it's one I get asked a lot when I talk to physios, because they find themselves in these situations a lot, as I do. And I think what I pass on is all the mistakes that I've made in doing this over the years, and tell them not to do that. So I don't think I've got a magical answer that says it works, or there is a simple way that it works. But what I do know is what doesn't work. And what doesn't work is going in too hard, too strong, and challenging people's beliefs and expectations too abruptly. And also denigrating other healthcare professionals in front of the patient also often doesn't work very well, because sometimes these people have good relationships with these other healthcare professionals, or they've got a lot of faith and trust in these other healthcare professionals, and they may not have that same faith and trust in you. And so if you go in there and start, quite robustly calling these people, misinformed, ill-educated, non-evidence-based, that can put the barriers up. And it can actually be detrimental to the relationship you have with the patient. So I always try to say to therapists, you're probably screaming inside, cursing at this other healthcare professional, but don't show that to the patient, and don't voice that to the patient immediately. My approach is to listen to these other views and opinions that are often not the best informed or not the most evidence-based, and sort of, nod away as I'm listening to them, maybe make a note about them. But then, at the appropriate time, I think it's about trying to offer to the patient whether they are willing to listen to perhaps a different explanation or a point of view. So I'm often using terms like, well, thank you very much for telling me this, or I hear this quite a lot. Yes, I agree. That's something that's often said about these things. But would you like to hear something else that I also know, and I also hear about these things as well? And most patients, when you frame it like that, that piques their interest, and they go, yeah, all right, then what else then? And then I often then apply my advice and my point of view across after that. And then when I've done that, and I can often see the patient looking a bit concerned or a bit confused, and then I throw it back over to them. What do you think about that then? And see what the patient says and see what that does. And often it causes them confusion. They go, well, I've never heard anybody say that before. So you're saying it's safe for me to bend forward when I've got back pain, when everybody else is telling me I've got to keep upright? I'm like, yeah. Well, what makes you think that that's the best thing to do then? Well, that's a great question. It's because, we've got some evidence that tells us it can help. But also what I think a lot of the time is patients don't really care about research and evidence a lot of the time.
Yeah.
I often say it's because I see it with my own eyes firsthand a lot of the time as well. And sometimes I'll say something along the lines, I've just had a patient in a couple before you, exactly the same situation as you. It's doing remarkably well with this approach that we've taken. So, it's these sort of things that I think patients prefer to hear, other patients' experiences and benefits from this approach, rather than what the latest research paper in JAMA says. They're like, are other people getting good results with this approach? And that's what I often say. So I again, just tread carefully, don't go in too strong, offer your advice, but make sure you get the patient's permissions to do that. And then throw it back to them to see what they think of it and what their questions and what their thoughts are on that. And that just starts off these great discussions. And I honestly think, it's all about being open, honest, transparent as much as possible, because patients really gravitate to that. And that's something else that works quite well. I'll often say to the patients, well, we're not quite sure. I'm not quite sure on that. Instead of, when there is uncertainty about things, I think that sometimes is an area that we stumble over. We're not sure how to manage that. And I often find that, there's this fear that if you say something along the lines of like, we're not sure, or I don't know, that it will cause a negative barrier. It'll make the patient feel like you're ignorant or you're not well skilled. But I've never come across that. I find most patients actually appreciate when somebody is honest and says they don't know. And what I always say is I don't just say I don't know and leave it at that. And I'll explain why I don't know. And I'll say to them, it's not because I haven't got information. It's probably just the opposite. It's because I've got so much conflicting information that I've learned over the years. So we're not quite sure what's the best approach, what's the best attitude, what's the best type of treatment for these things. And I find a lot of patients really resonate to that. They start to trust you more because you're not bullshitting them. You're not just pulling something out of your ass and just saying, this is definitely going to work. You're actually being, as a healthcare professional should do, open and honest and transparent. And I find many people just start to build more trust and faith in you when you start to voice that.
Right. And it's not as if you're saying, I don't know, to every question that they ask you and just leaving it at that. You're being very confident about your approach. And then if they dive into more specifics and you say you're not sure, then I think that shows that you're also confident about the last thing you said, because you didn't say, I don't know, to that.
Yeah. The most classic one I get is this going to work for me? Or that's the question I get asked a lot. Or the other one is about how long will it take before it starts to feel better? And I'm like, it's a crystal ball question. I'm like, I don't know. There's no way of knowing this. But it's not that we haven't got any idea at all. The reason we don't know is because there's huge variation in individual responses to all of these treatments. And these are the explanations and the other discussions I start to have. Now, patients don't like to be kept in limbo. They don't want to be in this real uncertainty. But they have to understand that it's not black and white. There are shades of grey.
Yeah.
And so, after that, I'm saying, but we do know, on average, timeframes are about this. So we might be saying to the patient, it could be 3 to 6 months of doing these types of exercises and movements treatments before your back feels like it's really robust and resilient again. But it might take a little bit longer because we also know there's some people that get flare-ups, it sets backs, other things happen in life, and there's other factors as well. So sometimes it might be a bit longer. So I like to use worst case scenarios, best case scenarios, and an average time frame in the middle to manage that uncertainty when dealing with patients' prognoses. When they ask me, how long will it take? When will I start feeling better? What should I be able to start to expect? And I'm like, we don't know because it's variable. It's highly variable. But let me tell you why it's highly variable. And then I might be talking about other things like lifestyle factors, which this guy's obviously got a few here as well. And that's a nice introduction to start talking about these other things as well and saying how it isn't just about the tissues and your back and your deadlift that's contributing to this. It's about other factors as well. And when we've got patients, that have got a raging long list of comorbidities, these things are often going to be a barrier to them getting back sooner than somebody that hasn't got a long list of comorbidities, or somebody that's got stress coming out of their ears and arseholes constantly 24/7 a day, compared to somebody that's in a life that's a little bit more relaxed and chilled and has got time to do their rehab and stuff like that. They're probably going to get a better result sooner and faster than somebody who hasn't.
Right.
It's a nice way to sort of talk about these other areas as well when you're discussing uncertainty and prognoses and how long it's going to take, because again, we can discuss all these other things that impact it.
Yeah. And I think the next case study that we have is going to illustrate that really, really well. There's a lot more lifestyle stuff and comorbidity stuff involved in that. But I have one more question about this case before we move on. Sure. And on your Instagram, you've posted videos of you doing like ugly lifts with the barbell, sort of bending and twisting and doing things that you don't conventionally see in the gym. And I have the same belief as yourself, which is that those things, when dosed appropriately and gradually and sensibly over time, can be absolutely safe. When you're working with someone like this, who is at the complete opposite end of the spectrum, right? They're not even bending their back when they're just dropping something on the floor or when they're sitting in a chair. Is that your end goal for them? Is to get them to be able to do these lifts, or is it something else?
So whether they have to do these lifts with a barbell in the gym, to establish and restore their confidence in their back, no, I don't think they have to. Would I like to be able to get somebody to do these things, who's had an episode of back pain like this chap has and who's perhaps got these beliefs and thoughts? Then, yeah, absolutely. It's something I would probably have as a final type of end goal to try and achieve, to be able to prove to him that all the information and stories that he's been told about having to do exercises in a specific way, otherwise he's going to get injured and damaged, won't hold up. Because we can show him that with sensible progression and programming, he'll be able to do other variations of lifts like Jeffersons, like twisters and things without any significant back problems or issues. It's all about maintaining and managing sensible progression and loading. So yeah, I think I would like to try and get these integrated into his sort of schedule of rehabilitation. But do I think it's necessary for him to do it? Probably not. I don't think he has to. There are some patients, unfortunately, that I've seen who have these beliefs that are very hard and sticky to challenge. And, no amount of coaxing and education and reassurance by me will convince them to do it. But their back improves, over time, because we know it has favorable natural histories. It just means that I haven't been quite as successful as I would have liked to be in my proving that their body is perhaps a bit more resilient and robust than they actually think it does. But, at the end of the day, their symptoms have improved. They've got better. Just because they've left the session and they're not feeling quite as robust as I would have perhaps liked them to, that's still not a failure. It's just, perhaps something that happens in life.
Yeah. Can't win them all.
No, absolutely.
Yeah. I'm the same way. I'm always gauging as to where these people actually want to end up.
Yeah.
And if after the first few sessions with them, you're having these conversations and they're going really, really well, then maybe you could start heading in that direction. But otherwise, it's about just letting them live the life that they want to live, right?
Absolutely. We can't enforce our goals on people coming to see us. That is definitely a goal that I would have. But that doesn't mean that that's going to be this guy's goals. He may be like, why would I ever want to do Jefferson curls? I go to the gym once a week to do my deadlifts. I want to get in and out as quick as possible. Why have I now got to add another 10 minutes onto my schedule to not only do my deadlifts, but now this other exercise that the physio says is good for my positivity and and my back as well. And I get it. I understand it. I'm not going to enforce or inflict my desires and biases on patients as much as possible. I've got to accept that some patients just don't value it. They don't see the benefit in it. They just want to do the bare minimum and the basics and the optimal work. And I get it. I do get it.
Yeah. Well said. All right. Let's go to case study number 2, unless there's anything else that you want to add.
No, I think that's a sort of nice synopsis of how we'd manage that. I want to say begging for lots of education, positivity, reassurance, but done in that careful, tactful, compassionate way. And I think, as I say, the best thing to do with people like this is don't overload them with education and research trials, but, it's these mini little experiments. It's about movement experiments, experiential learning, get them actually realizing that their body is better than it actually is.
Yeah. And don't rapidly overload them too much physically either, right? Otherwise, that whole approach won't work. If you're trying to do something with them and then you flare their pain up, to a really large degree by doing something that's a bit insensible for where they're currently at.
Absolutely. Yep.
Okay. Case study number 2. We have a 56-year-old woman with type 2 diabetes for over 10 years, hypertension that's controlled with medication, and she's postmenopausal. For her lifestyle, she's pretty sedentary. She has an admin job, low physical activity outside of work. She reported a gradual onset of right shoulder stiffness over the past 3 or 4 months, initially noticing with overhead reaching and dressing. Pain was mild at first, but has progressively increased and is now described as a constant dull ache with sharp pain at the end ranges. She denies any specific injury or triggering event. There's no numbness or tingling. In her daily activities, she has trouble fastening her bra, reaching overhead to put things on shelves, grooming her hair, and sleeping on the painful side. And most nights, the pain does interfere with her sleep. She has diabetes, as we mentioned. She has a sedentary lifestyle, postmenopausal, no prior shoulder injuries, and on X-ray, it was negative for degenerative changes. It's negative for things like fractures. And she got an ultrasound that shows a thickened joint capsule. So she just wants to feel better and maybe be able to use her shoulder more for daily activities and for some recreational activities like gardening. All right. So as we mentioned, lots of lifestyle stuff going on there, Adam. What do you think that this person is dealing with based off of that whole story?
Yeah, this is a classic diabetic frozen shoulder by the sounds of it, by the looks of it, by the feel of it. So, this is a horrible, miserable condition that definitely has no quick fixes or magic cures. And this is, again, an area where we've got to treat with some compassion. We've got to be open and honest again about managing their expectations, because if we start to promise things that aren't going to happen, again, that's not going to be well received and they'll lose trust and faith in us. But I also think we've got to add a lot of positivity, optimism, and reassurance into this message as well, because it's not all doom and gloom. It's just perhaps not as good as the person would want to hear or want to expect to hear from us. But there is, light at the end of the tunnel. We do see people recover from frozen shoulders. And there's often this discussion about them being self-limiting, which I often think is totally misunderstood by many people. Self-limiting conditions like this doesn't mean you can just go away and ignore it and do nothing about it. Self-limiting doesn't mean no interventions or treatment. It actually means it probably needs quite a bit of regular input and, treatments to try and help it become, self-limiting along over time. But what we're going to try and do here is with somebody is also not just focus on the shoulder, which is obviously their main problem, because this isn't just a shoulder problem. This is the shoulder is basically where all these other factors are manifestating. We've got to talk about how, sometimes this is probably one of the first signs that the lifestyle factors are beginning to have this negative impact on the body. And I think, when diabetes is present and it's not well controlled, our first goal here and discussion here a lot of the time with these conditions is that needs to be addressed and looked at quite seriously, I think, because no amount of capsular stretching, manual therapy, laser guided dry needling, is going to make the fuck all bit difference to somebody's pain or range of movement with a diabetic frozen shoulder if their diabetes isn't, first of all, better controlled. So that's the type of discussions I'm having normally right at the beginning, with these patients. I'm saying to them, look, my role here is to get your shoulder functioning better and to make it less painful. But I need some help here because I can't do it all myself. So we're probably going to have to get a multidisciplinary team involved. We are probably going to have to get your doctor, your diabetic nurse involved with this as well to try and help you get these things under better control. And the other thing we're also going to talk about as well is another non-physiotherapy approach here is the use of a corticosteroid injection. So again, I am a big believer of using corticosteroids with frozen shoulders. I'm not a fan of corticosteroid injections in a lot of musculoskeletal conditions because they are quickly used, overused, and sometimes too quickly, too regularly. But I often find it's the exact opposite with frozen shoulder. There's a lot of reluctance to use early corticosteroid injections with frozen shoulders, particularly in the diabetic population. I do get it because it does affect blood sugar levels. It's something that can upset your diabetic control, which is the exact opposite of what we're trying to do as well. So this is why we need doctors to help us with this situation, to say we need the diabetes under control. We then need to trial a corticosteroid injection with hopefully no major reactions to their glycemic control whilst they have the injection to try.
Could you explain that? Why would that be the case?
So steroids has this adverse effects to blood sugar levels, and it can last up to 2 weeks afterwards. I don't know the exact cellular mechanisms. I haven't gone into the physiology too much around that.
Shame on you, Adam.
I know. A little bit out of my wheelhouse, that is, if I'm being honest. But no, there's a lot of evidence out there. And again, I've seen it with my own eyes a lot of the time that say diabetics can have quite adverse glycemic responses for up to 2 weeks after an intra-articular steroid injection.
Wow.
So we just, if their diabetes is well controlled, those reactions and effects tend to be much minimal and much less problematic. It's the ones that have got poorly managed diabetes where it does start to cause problems. So say first goal here is get the diabetes under control and then start to think about getting an injection into the joint sooner rather than later.
Mm-hmm.
And as I say, steroid does get a bad rep, and rightly so, for a lot of musculoskeletal conditions, but there is good quality level 1 evidence that says it's the best way to get their pain under control. The thing we've also got to look at here is, again, is this truly a frozen shoulder? Because although it sounds like it is, it definitely, presents like it is. I have been fooled many times before with frozen shoulder when it actually isn't a frozen shoulder. Because on paper, it's a very easy diagnosis to make, but in real world experience, there are some things that very much pretend to be frozen shoulder.
Okay.
And one of the most common ones in patients like this is pain guarding. So painful body parts can present stiff and restricted, capsular end feels, and all these sort of things that you'd expect during assessment. Just because somebody has painful loss of range of movement doesn't mean their structures or their tissues have got some adverse pathology. It can be just the pain that's stopping them from moving. So there's been a number of really interesting small little case series done on people with frozen shoulders, particularly, ladies like this at that sort of age range, classic frozen shoulders, who get their shoulder range of movement reassessed when they're unconscious under general anesthesia. And we see that their range of movement is normal. That can't be a pathological restriction to a joint capsule. Now, we've got a little bit of help here because she's had some imaging. So that's probably, given us some more certainty that this is likely to be a capsule problem, because we've got this ultrasound report that says thickened capsules. I don't always trust those. Because I know interpretation of thickened capsules is highly dependent on the radiologist doing it, and it isn't the most reliable or accurate way of measuring it. So it is an area that I often find sometimes, we get fooled. We think this is a capsulitis, a fibrosing joint capsule, and instead it's just a painful, irritated shoulder. And when that pain and irritation settles down, there is no fibrosis, there is no capsule restriction. Because a true frozen shoulder, that fibrosis and thickened capsule doesn't miraculously improve. It doesn't come back 6 weeks later with range of movement changes of 10, 20, 30, 40% improvements. That just doesn't happen. But we see this clinically with people with so-called frozen shoulders a lot. And when I start to see this presentation and I start to see the improvements really quick, much quicker than I'd expect, a little part of me says, that probably wasn't a true frozen shoulder. And the other thing that's also making me, with this case study, a little bit thinking, is this true of true frozen shoulder? Is the mildness of her pain. Because in my experience, diabetic frozen shoulders are much more painful, much more acutely painful, and much quicker occurring than the non-diabetic frozen shoulder. So with diabetic frozen shoulders, I often find pain is really acute, really severe, really life-changing, and it comes on really dramatically and quickly. This slow, gradual build-up that she's had, and now this reported constant dull ache. There's a little part of me that's starting to think there, is this truly a capsulitis? Is this truly this irritated capsule? Because, when it happens, when you look at this pathology of frozen shoulder happening, it irritates the hell out of the synovium. It changes the pathophysiology inside the shoulder capsule hugely. Gross amounts of angiogenesis. We see this cellular proliferation. We see myofibroblast cellular proliferation. We actually start to see contractile tissue elements in the capsule, not only thickening it, but drawing it in as well. And we know that synovium is richly innervated. The pain just shoots up to 15 out of 10 for most of these people. And it happens within sometimes a couple of days, really severe. So when I hear this story about frozen shoulders coming on slower, more gradual, without this sort of severe response, again, a part of me said, I'm not going to say it definitely isn't, because I do think there's various different aggressivenesses of frozen shoulder. But often with a diabetic, the aggressiveness of the condition is quite high. So I'm expecting to hear sudden dramatic onsets of quite severe debilitating pain. And night pain is the worst one. It wakes them up regularly. They can't sleep. And it hurts at rest as well. It's aching quite badly when they're watching the TV or just trying to, sit down quietly somewhere.
Right. So how else can we be sure that it may be a frozen shoulder? I hope physios aren't putting people under general anesthetic and sort of moving the shoulder, doing a before and after test. But are there any clinical tests that we can maybe rely on? And also, can you touch on x-rays as well?
Yeah, so the other type of conditions that can sometimes mimic frozen shoulder in this type of population could be osteonecrosis. And the reason for getting an X-ray is often to see whether, there's any sort of bony irregularities or changes. But early osteonecrosis is often very difficult to spot on an X-ray. It's only when it enters into about stage 3 that you actually see the necrosis of the bone, that you spot it on an X-ray. So stage 1 and 2 osteonecrosis are not often seen on X-rays. But osteonecrosis would often affect those that have been on long-term steroidal medication. So we have risk factors that we know are closely associated with osteonecrosis. STARS is the acronym we use. So long-term steroid use, trauma, so a bang or a knock, fracture, dislocation to the shoulder increases the risk, alcoholism, radiation therapy, and sickle cell disease. These are the big 5 horsemen of osteonecrosis of the human.
Could that trauma be previous trauma, not recent trauma?
Yes, it can be. We could be talking 6 months down the line, but we're not probably going to say trauma that happened 30 years ago. No. So it's going to be a relatively recent trauma, but it doesn't have to be only a couple of weeks before it happens. Sometimes it can be a couple of months before it starts to become pronounced, because this osteonecrosis, as they can develop gradually and slowly as it goes through these stages. And as it gets worse, obviously the pain and the limitation get worse as well.
Okay.
So, yeah, that's a little bit concern, as I say, of a frozen shoulder or an osteonecrosis pretending to be a frozen shoulder. But to answer that question, is there any way of being 100% definitive that we've definitely got adhesive capsulitis, this altered pathophysiology in the joint capsule, clinically with anything we do? And the simple answer is no. There are no reliable 100% foolproof imaging techniques, particularly in the first 6 months of this condition. So, we very rarely find anything majorly altered that we can see with any reliability. So although capsules do thicken, we're talking the difference of 0.5 millimeter sometimes in some people. So that's incredibly hard to spot on ultrasounds and MRIs. There is a bit of talk about the coracohumeral ligament that sometimes thickens a little bit more excessively and aggressively in the earlier stages. So there have been some studies that shows if the coracohumeral ligament looks excessively thick, they normally suggest anything above 3 to 4 millimeters on cross section, that can start to indicate this adverse thickening of the capsule, because the coracohumeral ligament blends in with it. And another sign we sometimes look for is this effusion around the long head of biceps. So the long head of biceps is actually, the sheath that around the biceps is actually a continuation of the joint capsule, which is a common misconception as well. A lot of people think it's a separate tendon sheath. It's not. So when we see this effusion around the long head of biceps, it can tell us somebody's got this reactive synovitis going on inside the joint capsule. So that is something that could also be an indication. But really, the only way is by arthroscopic investigation. You actually go into the shoulder and you visually inspect the joint capsule and you look for the collagen disorganization. You can see the angiogenesis in there, visually. Or a tissue biopsy sample where you take a biopsy from the capsule and send it off to histology and look to see whether you see this myofibroblast cellular proliferation.
Again, that's not for physios to do in clinic.
This is something that we're not going to be starting doing. You're not going to start taking needle biopsies of shoulder capsules in your clinic. Absolutely not. No.
I hope not.
Yeah.
Okay. So we have some things where we could be a little bit more sure, but never completely sure that we're dealing with this. Mm-hmm. So let's say that we'll alter the case study a little bit, and we'll say that this woman has severe pain and a more sudden onset of her pain. Let's throw in all the factors that will make you a little bit more confident that it is a true diabetic frozen shoulder. How long are you telling this person that it may last for? And again, going back to the last case study, we need a range, right? Yep. You can't be completely sure about that either.
Yeah. It's definitely not going to be 6 weeks, that's for sure. So the most common time frame for most musculoskeletal conditions, 6 weeks, is often what I hear doctors and physios saying. So no, it's definitely not going to be short. It's not going to be quick. So the research, again, shows a lot of variation, with best case scenarios 12 to 18 months. But if I'm being honest, in my clinic experience, very, very, very few frozen shoulders are going to be feeling significantly better in a shorter period as 12 to 18 months. I'm probably thinking less than 5% of all the frozen shoulders that I see get that sort of resolution in that sort of short time, but they could do. So that's the most optimistic outlook.
Yeah.
Worst case scenarios, we see some people still suffering with severe pain and disability up to 5 years after onset. So that's the really extreme cases. So they are unfortunately, again, out there, but again, not that common. So I'm probably going to say I only see a few with that type of history as well. The average median duration is around 30 months. So 24 to sort of 36 months is often what I'm saying to people. So 2 to 3 years, unfortunately, before the shoulder feels significantly improved. Yeah. Now, that doesn't mean it's going to be 2 years before it feels better, because it does improve over time during that 2 years. But most people report what they consider to be an acceptable shoulder with, after they've had this condition, say around the average of that 30-month duration. Yeah. So it's quite depressing to hear that, to be told that this is going to be a long-lasting condition is quite a difficult pill to swallow. And again, I sometimes find patients want to go and get second and third and fourth opinions, and they go therapy shopping here particularly if I'm the first person they've seen for this condition. And I get it. I totally do. Yeah. I mean, I'm not going to accept anybody who tells me that I've got a condition that is, long lasting, not much you can do for it. Be patient, keep looking, positive and all that sort of stuff. Like, bugger that. I'm going to go and see if I can find somebody who can fix it sooner, quicker, faster. And so these patients, I often find, do go therapy shopping. And there's all sorts of charlatans and shysters out there who will promise them all sorts of crap, all sorts of nonsense, from rubbing on horse placentas, using bloody magic
Have
machines.
You actually heard that?
I've heard, yeah, a ground up, a pulse of a horse placenta. Apparently it's got it's stem cells. That was what it's all about. It's the stem cells in the horse placenta.
Oh, well, I believe that then.
That can leach through the skin. It wasn't even injected. It was in a thing, a topical thing you put on the shoulder. And yeah, it's like, some of the things.
I guess it's a good thing that it wasn't injected. That's a positive, I guess.
Yeah. But yeah, apparently the stem cells from horse placentas. But yeah, all sorts of crap. Shockwave is sometimes bandied around as the latest treatment for frozen shoulder. Laser therapies, all the machines, TECARs, all this sort of stuff, all claiming, to improve resolution, speed up healing processes. And there's just no evidence for it. It's just nonsense. And I find, sometimes these patients who are desperate and everything, they get taken advantage of because they are vulnerable. And these people out there, do they do it maliciously? I don't know. Sometimes I think some of these people who sell these shitty interventions probably do believe their own bullshit a little bit. They probably get some self-fulfilling sort of feedback from some of the patients who didn't have frozen shoulders, said, oh, you fixed my frozen shoulder, when it wasn't probably a true frozen shoulder, it was a painful shoulder. So then maybe that sort of positive feedback reinforcement where they do believe they've got these latest cures for it. But I'm sure there's some people out there that know what they're doing is a complete and utter fucking fallacy and farce, and yet they're still doing it because these people are desperate. Mm. That's the shit that winds me up the most.
Of course. Yeah. So let's say the person tries this therapy shopping, doesn't work out for them. The horse placenta doesn't do the trick. They come back to you and they say, okay, Adam, I believe you now.
Yeah.
What can I do?
So
other than getting the diabetes under control, right?
Yeah. Diabetes under control, pain under control. So that's where the steroid, again, is probably the most effective thing to use. So I'm going to make sure that they've got that pain modulation with the steroid hopefully working. How many steroid injections it takes to do that, again, is variable in my experience. Sometimes it's one, and that's enough to dampen things down, make their life more tolerable. Other times it can be up to 2 or 3, normally with sort of 2 or 3 months in between each one to get on top of the worst of the pain. But once they're probably okay and they're feeling their pain is okay, then, what I tried today is movement is key. We want to get the shoulder moving on a regular basis. But what I don't think needs to happen is we don't need to put aggressive mechanical signaling through the joint capsule. Mm. So again, when we look at the pathophysiology of a true frozen shoulder, we've got these adverse myofibroblast cells proliferating. And myofibroblast cells are listening out for tensile stimulus. And when they get tensile stimulus, they'll start to produce more contractile elements. And that's the exact opposite of what we want. Now, there's no real robust evidence behind this, but there is a little bit that says if you get too aggressive with a frozen shoulder, it delays their outcomes. It actually slows them down. And I think the reason for this is because we're probably making the pathophysiology in the joint capsule worse. So I'm not a big fan of aggressive manual therapy, long duration, painful, end of range stretches and holds for somebody with a frozen shoulder that's probably within the first year or 18 months of its duration. Because I think that pathophysiology inside that shoulder needs a time, that probably year or so, to calm down before we start asking them to move aggressively to try and get the tissue back to square one again. So that first year's history, it's all about maintaining range of movement, moving the shoulder regularly and gently, but it's not aggressive end of range stretching. So I like things, like simple tabletop slides, little pulley type movements where they move it with some assistance at low intensity at slow speeds. They're going up as far as they can. They are going to end of range, but they're not trying to pull through it, and they're certainly not holding time under tension there for too long. What I often say to these people is maintain the range of movement you've got in these painful stages. Don't think about trying to improve it. If it improves, great, let it happen, occur naturally on its own. But don't try to actually physically pull it through pain in a desperate attempt to restore range of movement. That will come on in the second stage. Once the pain has gone and you're in this second stage, that's when I think it's safer to start pushing things a bit more. And try to encourage, other factors, lifestyle, sleep, nutrition around all that as well, to try and obviously get things to improve as quick as they possibly can.
Yeah. And then when it comes to strength and maintaining that, are you giving them any form of resistance training to at least maintain muscle mass and strength?
Same principle. I am a big fan of, doing generic exercises for these long-lasting, multifactorial conditions. So I think there's absolutely no reason why somebody with a frozen shoulder can't do other forms of exercise to maintain their health and fitness, cycling, gym-based exercises, leg presses, even working and exercising the other shoulder, I think is a great option as well. So, if this other painful shoulder doesn't feel like it wants to do any aggressive stretching or strength training, work out the other shoulder, get that shoulder moving through as much range of movement as it can, get that one doing some overhead shoulder presses on a machine or with a dumbbell or a kettlebell. I don't mind, I don't care.
Right.
Get that one doing some lat pull downs on its own. Those exercises might also have a positive effect on the other side, might get a bit of cross education, but the main thing is it's just going to work your body, and get those systemic effects with exercise working. It'll help release a little bit of endorphins, the painkillers as well. And also, again, maintain muscle mass, bone density with somebody of this age is important. Postmenopausal, absolutely. So we could use that as a way to help their body more holistically rather than just focusing on the shoulder. Yeah. But then when that gone into that second stage, when they're through the worst of their pain and they've had a year or so, things are starting to feel okay now, that's when I'm going to start saying, let's start moving this other shoulder and strength training it and exercise it. I'm a big fan of using sort of what I call strength stretches rather than static stretches. So using resistance through range of movement to challenge the end of range of movement. I find this one of the best time effective and probably range of movement effective ways to restore stiff, flexible or inflexible joints. So using dumbbells, machines, again, it doesn't really matter. Find some resistance that you apply to a joint or a body part that feels like it doesn't want to move. Work it through that range of movement and build up its tolerances with the weight progressively and steadily, but try to move it really slowly. That's the key with this stuff. Time under tension. So
in the second stage.
Yeah, in that second stage. So, their pain is minute. Then now they're going to get some reaction because anybody who's done heavy, slow type of resistance training tells you for 2 days afterwards, you feel sore. You're walking down the stairs like you're crippled if you've done some really heavy eccentric squats on your legs or your hamstrings. Everybody knows that.
Yeah.
So it will create some post-exercise stiffness and soreness, but it's actually a good type of stiffness and soreness is what I try to tell patients in this second stage. But if you did it in that first stage, that's not a good type of stiffness and soreness, no.
Got it. All right. Well, I think that does a good job at illustrating how frozen shoulder is maybe one of the more quintessential conditions where focusing on the whole person and their overall health is very, very important. Before we move on, Adam, to the last one, which I think is a bit more straightforward, anything that you want to summarize here or any final comments?
No, like you said, frozen shoulder condition is not just a musculoskeletal joint condition. It does need, stepping back and looking at the person's comorbidities and life factors and stuff along those lines. Metabolic disease is a classic one, but so are other things. I always suggest, people, when they've got a diagnosis of frozen shoulder, it looks quite robustly that it is a frozen shoulder. Go and get some blood tests, check your thyroid function, check your blood sugar levels. These other factors do want to be screened for, because you may find that this is one of the earliest signs that says you've got endocrine health issues, you've got metabolic diseases. So, even if you haven't had a diagnosis of diabetes and you've got a frozen shoulder, still go and get a blood test or get your doctor to run some tests to make sure that you haven't got it and this is one of the first symptoms of it.
Okay, beautiful. All right, last one. You ready?
Yep.
Okay, case number 3. We have a 45-year-old male, no major medical issues, no previous shoulder surgeries, but he is dealing with some intermittent sports-related shoulder strains, but nothing too persistent until recently. He's a basketball player. He's played his whole life pretty much, and he typically plays weekly once his symptoms allow him to play. So 2 or 3 years ago, in the last 2 or 3 years, he's noticed gradually worsening right shoulder pain. The symptoms come and go, often feeling manageable after periods of rest. And when he feels good, he tries to play basketball, but the shoulder generally will flare up, and the cycle has become increasingly predictable and worsening over time. After a game, he notices a reduction in his overhead range of motion. He has difficulty lifting the arms fully overhead for a few days, and then his mobility and symptoms gradually return to baseline. So the pain is located along the front and side of his shoulder, and sometimes when it's particularly bad in particular reaching movements, it can shoot down to his elbow. When he's playing, it's reproduced with overhead activity, like shooting, passing overhead, jumping up for rebounds, going for blocks, but also in life when he's doing things like reaching behind the back or putting away things on a shelf. In terms of the clinical exam, he has positive shoulder impingement tests like the empty can test and Hawkins-Kennedy. He also has scapular dyskinesis on the affected side, so his shoulder blade moves kind of funny when he's moving his arm. Scapular assistance tests significantly reduce symptoms. So when he's reaching overhead, if you help him do it, when you put your hands on his shoulder blade, it sort of helps him out and reduces his pain. And when we measure his strength with a dynamometer, we see that it's weaker and painful compared to the non-affected side for external rotation. Again, no numbness or tingling. And he has just difficulty playing basketball. And that's his main goal, to get back to playing and to have a good feeling shoulder again. All right. So what do we make about those impingement tests and the scapular dyskinesis and his reduced strength? Does that mean that he has impingement and that the key to this is reducing the impingement and getting his shoulder blade to move in a correct way?
No, absolutely it does not. You've set that up nicely there, Noah. Well done. So again, the common narrative is with these type of shoulders, adverse biomechanics, reduced subacromial spaces, impinging of rotator cuff tendons and bursas as you're lifting your arm up and down overhead. And, you've got to correct these biomechanical dysfunctions to improve these symptoms. But that's just nonsense. All those tests tell you is somebody's got a painful shoulder. That's pretty much what they're telling you. They're confirming you what the patient's already told you. Their shoulder hurts to lift it up or put it into a certain position. So that's exactly what we do. We go and lift it up, put it in a position and say, does that hurt? And they go, yeah. It doesn't give us any diagnostic ability about where the pain's coming from, because none of these tests are specific to an individual tendon of your cuff or a specific part of the bursa or anything along those lines.
It's funny. I did jiu-jitsu for a couple of years, and the Hawkins-Kennedy is so close to a Kimura, like an actual submission hold that you could do in jiu-jitsu. It's like, this hurts. That's interesting.
Yeah, I think they probably learned a lot from people in pain or hadn't got pain and trying to put them into pain. And they're like, we could use that to our advantage. Yeah,
right.
Let's use that clinically. Yeah. They'll be doing arm bars and what's the other one? Heel locks next as well to diagnose things. But yeah, no, all that tells us, as I say, is this person's got a shoulder, and this is a classic case here of somebody's shoulder that's just unable to tolerate the loads and the demands that he's placing on it. And it's often because he's not being consistent. So he's going through this boom and bust cycle on a weekly basis by the sounds of it. It's the classic weekend warrior type of issue that you see in the runners that only go for a run on a Sunday. And they think, oh, I haven't done any running all week. I need to do my 20 kilometers a week. So I'm going to do it all on a Sunday. And then they wonder why their knees and their hamstrings and their Achilles are all aching and sore for the whole week afterwards. It's just this classic situation of life gets in the way of us trying to be consistent with our activity and exercise. And I get it. I struggle to fit it all in. And I'm not always consistent, and nobody is, with it as well. And when you're not consistent, your body recognizes it and feels it. And I know that personally, my own self. So with somebody like this, who is just playing one game of basketball, perhaps with no other types of exercises at all during the week, apart from sitting down at work and doing whatever he does, this means that his shoulder is just getting a lot of load, a lot of stimulus in a short period of time, all at a very short period of time. So we need to explain that to him. We need to say to him that this is often, it's a tissue sensitivity, irritability thing in the shoulder. The most likely diagnosis is going to be the rotator cuff tendons, of course, But this is going to affect the way his shoulder moves, which is why we're seeing this wonky scapula, or we think we're seeing this wonky scapula, because I often find a lot of therapists get this post hoc reasoning with scapulas. Oh, look at that scapula. It's really asymmetrical. That's why this person's got this problem. I'm like, it's a consequence of this problem. It's not a causative factor of this problem. And you don't know that because you haven't seen this guy before he had shoulder pain. Did he have a shoulder blade that was doing that even before he had the pain? Well, I don't know. Exactly. You don't know. So you can't say this is a causative effect without examination, investigation before he had pain.
Now, let's say that he, for some reason, sets up a camera in his room and just does full body analyses of himself. And he knew before he ever had this issue, his shoulder blade does move funny. Does that change what you do at all?
No. So if he had a asymmetrical looking scapula beforehand, he had zero pain and dysfunction, then that's normally just perfect normal variation and anatomical asymmetry. Because again, something that we often believe is that everything has to look symmetrical and perfect from left to right. And that doesn't make any bloody sense at all, because the right shoulder, if you're right-handed, is going to be doing things completely different from your left shoulder. So why you'd expect it to look the same and act the same and do the same things as a shoulder that doesn't do the same things, to me, just doesn't make any bloody sense at all. So no, we're not going to stress too much about asymmetry. We're not going to stress too much about something that looks a bit wonky. We're probably going to say it's a consequence rather than a causative factor. But even if it doesn't change after your pain goes, then we're not going to worry about it, because there's no way of knowing whether it is just this normal asymmetrical variation that you've got. The main thing is the symptom of pain as you're doing the task and activity. Those are the things that we want to calm down. So this is somebody who's going to probably, again, have this sort of graded activity approach, not a graded exposure approach like we'd have done with the back pain patient. We're now going to grade their activity levels to flatten out these boom and bust cycles. So that sometimes means we have to stop them from playing their sport to begin with. And I'm not a fan of doing that as much as often as I can, because I hate telling people to stop being active when they're not getting much activity. But we might want to think about replacing that time with another activity that's probably not going to irritate his shoulder as much, because that shit might need some time to calm down. So we might give him a couple of weeks of saying, let's knock the basketball on the head. And let's spend those couple of weeks instead, when you would normally play basketball, doing something that doesn't irritate your shoulder quite as severely, but it's still going to build its capacity up to tolerate playing basketball a little bit later on. So we're going to sort of smooth off that peak of irritation that he's getting at the weekend when he plays this game of basketball by reducing it and giving him something else. And when that starts to calm down his pain, which hopefully it will do, now we've taken away the sort of the irritating factor. Now we're going to start to grade his activity around that shoulder to gradually different things to get it robust and resilient. And this is where I'm a big fan of, multiple stimuluses here. So getting a shoulder used to some heavy, slow type work, some higher rep range work at slightly faster, and then obviously some explosive sort of plyometric work as well. So we just want to try and work out a program of activity and exercises that's going to give his shoulder this variation of stimuluses to get his tendons and his tissues able to tolerate things that it needs to tolerate when he plays basketball. Now, basketball is often where you're moving at high speeds and high rep ranges and high frequencies. So we want to get him to there, but a little bit of slow building of strength and capacity first is often a good step to start off with, and then progress from there.
I would typically do the same thing with people. I often would prescribe exercises for an issue like this. But do you think it would be feasible for someone like this if they said that, my pain just gets worse and worse as I play, especially around the 2-hour mark? So they're playing maybe for 2-3 hours all at once in 1 week. Do you think it'd be possible for this person to recover by saying, hey, why don't we try maybe playing, if it fits your schedule, basketball a little bit more frequently once your symptoms calm down a little bit, but just for a shorter duration? Maybe we play for half an hour or an hour at a time, multiple times a week, and just that dosed over time would be enough to condition a shoulder? Or do you think someone like this needs exercise, like resistance exercise?
Great question. And I'm going to say I don't know. And I'm going to say it depends. But I do think, the best type of rehab for something like this is doing the thing that it needs to be doing. Definitely. So that definitely is going to come into the equation. Whether you could just use that and nothing else is the bit that I am uncertain about. I know if you were to look at a runner, we could probably get away with a runner using graded activity to running to get them back to running. But would we still want that runner to do strength training? Not just because it's going to help their current situation, but also because of the other factors that we know as being an evidence-based practitioner, that strength training can improve their efficiency, improve their performance, possibly mitigate their risk of injury, maybe. So I understand what you're saying. That is because, the basketball can be the rehab, can be the therapy to get them playing basketball. And yes, I think it can do. So you could ask him to go through this progressive program of playing basketball, and that could be enough. But there's still a part of me that says, if I'm being a good, rounded, evidence-based healthcare professional, I should be asking him to at least try once or twice a week to do some other type of resistance-based training for his shoulder to help him play basketball better in the future, or to mitigate risks of problems coming back later on.
Got it. I think if I was working with someone like this and I offered resistance exercise as a potential solution and they said, I hate doing it and I really, really don't want to, the way that I think I would phrase it to them would be, listen, I do think this will help you. And maybe it is possible to just use basketball as rehab. But if that doesn't end up working out, I just want you to know that we have this option and we may want to revisit this conversation. Do you think that's sort of a feasible thing that we could suggest?
Yeah, again, you find that sort of, shared decision-making processes with your patient normally helps build that, engagement and likely to get things done, and they listen to you better. Yeah, I get that. There's also part of me that says, with people like this, I understand that. But there's also part of it that they've got to listen to the professional so that perhaps knows a little bit better than they do. And I know people don't like to do things, but sometimes we have to all do things that we don't like doing. I don't like eating broccoli, but I know it's good for me. I know it's a good source of iron and vitamins and stuff. And so, once a week or twice a week, I'll have some broccoli. And I'm like, I'd much prefer an extra portion of chips. I'd much prefer to have that instead of this broccoli. And I think it's the same thing, when you've had a problem and you've got an issue and you go and see a professional and they say, look, we think this is the best thing for it. You've got to sort of accept that. You've got to sort of say, okay, all right, I don't want to do it. I don't like it. But hopefully if you've got a professional that is going and listening to you, they're going to help you find a strategy that makes it less demanding. So they're not going to overload you. They're not going to ask you to do it every day. They're going to find things that probably fit into your lifestyle, hopefully. And it isn't too much of an arse ache for you to do. But I do think some people just need to do things they don't want to do.
You just need to eat your broccoli sometimes.
Yeah, just fucking pick up a weight, go to the gym, or even just do it in your home, okay? And do these 3 sets of 10, 2 times a week. That's all I'm asking for you.
Yeah. Okay, fair enough. I think that one was pretty straightforward. The main points we wanted to sort of cover there was that there's this boom and bust cycle going on,
Mm.
that there's no other form of resistance exercise, whether or not we can use basketball as rehab, and how to interpret all those funky tests that we saw, like the impingement test and the scapular dyskinesis. Anything you want to summarize there, Adam?
Yeah, to any physios listening, do all these tests occasionally with your patients. All right, I don't want anybody to be put off from doing them, because it is useful to know where pain is and how irritable and sensitive it is by doing things like, Job's testing, empty can, full can testing. Still look at scapulars, but take all these things with a big pinch of salt. Don't think that you're able to give any diagnostic reliability or accuracy about exactly what the problem is and exactly where the problem lies. But that doesn't mean, you're not going to do your thorough assessments, and it doesn't mean you're not going to do what you would normally do with your patients with these things. Because I often find that's another argument I get. Oh, Adam says you don't even need to bother looking at people. You don't need to bother examining them because he knows all these tests are shit, so he does nothing. He just goes and gets people doing deadlifts. I'm like, no, come and watch me do an examination. You'll see I'll do all the fucking things that you would do in your normal physiotherapy assessment. Yeah. I just know that it's not giving me all the information that I used to think it was.
Right.
But it's still useful to know whether somebody has got pain in these positions and how strong it feels and how irritable it is and how sensitive it is. These things are really useful to assess during your assessments.
Yeah.
It's just not telling you it's the supraspinatus tendon.
Yeah, I quite like the scapular assistance test, not because it tells me what's going on at all, but when people are doing it, hold on, stay with me.
I'm holding back.
Okay. When people are lifting their arm overhead and it hurts, and then I help them out a little bit, I just use it as an example to show them hey, right now, it seems like we could get your arm in a similar position with some help. And it seems like that's probably telling me it's something muscular. I'm putting the joint in the same position and it's not being as painful as it was. So this tells me that if we just maybe build it up over time, we'll feel a little bit better. And it's a good sign that your symptoms can change. Tell me why I'm wrong.
All the scapular assistance test does is deload a shoulder.
Yeah.
You just facilitate the movement and deload a shoulder. But you've had to use your magical special hands to do that. All right. Mm-hmm. And that's the bit I fucking hate, because I think these things are more for the therapist's benefit than the patient's benefit. Because it makes you feel like you're actually doing something. But if you got a positive scapular assistance test, I will bet my left testicle that you'll get a positive response with a banded arm pull down.
Yeah, but I use that as for my exercise prescription.
Mate, just do the banded arm pull down. Don't worry about fucking about with the scapula to show how good your magical special hands are, whether you can feel the inferior pole sticking out more or not. Just do the banded pull down, because I can guarantee on the way back up it'll feel less painful than it does when they're not holding onto the band.
Right.
So it's just deloading the shoulder. And again, that is I totally agree with the second part you said. It's a great win for the patient to realize their pain is modifiable, and you've got a strategy to reduce their pain on movement. It can be a great confidence booster. You just don't need to use your magical hands to do that. Simple rubber band or holding onto a pulley machine or sliding the hand up a duster or up the wall will do it just as effectively. Absolutely.
Right. Fair enough.
And the other reason
I may still do it,
because the person who came up with it also really fucking annoys me as well. That's another bit of personal background information, but we won't go into that because that's another podcast for a third time, Noah.
Yeah, that won't be mine, I don't think, but maybe a private one sometime. Yeah. Anyway, Adam, I think this really served the purpose. I think that although people can't just come into your room and watch you assess people and see you do all these tests and these questions, I think it really allowed people to gain access into how you actually think and navigate all these clinical scenarios. So thank you for sharing all of your clinical wisdom with us.
It was a pleasure, Noah. Lovely talking to you again, my friend. And thanks for the invite second time round. And maybe we'll have a third one in the future. Who knows?
I'd be happy to do it. Anywhere that people could find you or connect with you online or learn from you?
Oh, I'm a shy wallflower. You can't find me anywhere at all these days, Noah.
We can keep it that way.
Yeah, I'm all over social media, mate. I mean, if you're a physiotherapist and you don't find me, I'll be very surprised. And I know that sounds arrogant, and I didn't mean it.
No, it's true. It's true.
Yeah, but yeah, you can look my name, Adam Meakins, on Facebook, Instagram, Twitter or X is what it's called now, or my pseudo alter ego is the sports physio. You can also find me underneath that as well.
Awesome. Okay. Adam, thank you again. I had a great time chatting with you, and I really, really appreciate you coming on.
Cheers, Noah.
Cheers.